Like, I had to work and it was so complicated with the pharmacist and that and I had the bill because we couldn't get off the drive-through. And there were people waiting for their meds. And I'm like, well, I have another line. I have a line for an hour. So if I tell you but and then I can't go do it, he can't go do it. Right? Somebody's gotta do it. So yeah. Oh yeah?
Yeah.
They just handed her. They were
Yeah, he was really good.
It was so funny because he came like I had been working there for like a couple of days and he like remembered me and he was like talking to me and then so he like knows me and like all the other people that don't know me and they're like
All right, good morning. Let's get started. All right, let's get started. So a lot of you probably haven't, or you've probably seen me walking around. So I am Simran Margot, Dr. Margot. I started earlier this year as new faculty. My background is pharmacogenomics. You can come and talk to me about pharmacogenomics anytime. If you come and talk to me about pharmacology, I've probably not done that for about 5 or 6 years. So all of this has been a big kind of relearning curve for me, but it's kind of fun. So a lot of you might have watched the constipation, diarrhea, IBS. That was actually, I found that pretty difficult to do. There was a lot of new information since I did pharmacology, which has been a while. But yeah, it was interesting to learn. So like I said, this is a learning experience for me. Not a lot has actually changed when it comes to peptic ulcers and treatments for GERD. So today we will go through the pharmacology, and then next week you will have Dr. Marks who will come and talk to you about the therapeutics of this. So I think her lecture is a lot more case-based, how you can use and some of the mechanisms of actions which I will talk to you today about. And when you prescribe these drugs, kind of in your mind you're thinking, okay, I kind of know how these work, just in case the patient ever asks you. Okay, so let's get started. So these are your very kind of broad learning objectives, and this is pasted exactly as it is on Canvas, I believe. Like I said, we'll talk about drugs used in the treatment of GERD and PUD, but also things like just dyspepsia. So we will talk about antacids, H2 receptor antagonists, proton pump inhibitors, the prostaglandin analogs, and some of those compounds, I think the colloidal bismuth compounds are actually mentioned in my other lecture, which I recorded and posted on Canvas. Okay, so if you actually look at the first 3 and maybe even the 4th kind of group of medications there, they kind of describe themselves, right? Antacids, antiacids. The second one, you're blocking H2 receptors. The third one, you're blocking proton pumps. And the third one is an analog of prostaglandins. So you already have a kind of a basic idea of how these drugs are working. All right, so to get, I suppose, everyone to the same level or everyone up to speed in terms of the physiology, I'm sure you might have covered this in other lectures, but just to get you, I suppose, up to speed in terms of what are we talking about? We're talking about the stomach. Where in the stomach or where in the gastrointestinal tract are we focusing on? The stuff where I kind of label as background information, this is technically not examinable. It's just for your information. Within those slides, I will kind of highlight and make points to certain, I suppose, points. Those, I suppose, will help you to understand how the drugs work on later. So if at any stage you're like, hey, I'm not sure, please just, feel free to yell out. Let's make this as interactive as possible. Okay, so this is your kind of first slide, and like I said, this is all very background information. This is kind of overload of information, but from this slide, to kind of understand some of the drugs we will talk about, let me see if I can, all right. So some of the information, or some of the drugs that we will talk about, specifically we will focus on drugs which kind of act in that part of the stomach and that part of the stomach. Now you'll see I've said that and that, right? I haven't said, okay, I'm going to say now, fundus and corpus, but you don't need to know that. right? You just need to know that different parts of the stomach or different parts of the upper gastrointestinal tract are broken into different areas or different portions, and each of them have different cells, okay? The two things I'd like you to remember are, or what I'd like you to remember off this slide or appreciate off this slide, is what is indicated in bold, all right? So, where are my notes? I make notes, and I think when I was delivering the lecture online, I was referred back to them to make sure I am telling you exactly what you need to know. Okay, so one of the important cells we will talk today about are called parietal cells, all right? And these are important because these secrete what? Anyone know? It's on the slide. What do parietal cells secrete or release? Sorry? Excellent. So eventually you get hydrochloric acid in your stomach, but they actually only release H, right? They only release the hydrogen. But hydrochloric acid as an answer is not wrong, right? Okay. Something else on this slide which I want to mention. Okay. So we've discussed parietal cells. Okay, the chief cells. These secrete pepsinogen. Anyone remember what pepsinogen does? I saw this. Yeah, excellent. What does it protease? Yep. Pepsin. It makes pepsin, right? And that's also important. So that's great. Just remember like that's important, okay? So I won't spend too much time, just want you to appreciate that we will be talking about parietal cells, we'll be talking about the chief cells which secrete that pepsinogen. All right. This is just a different view. Let me bring that up. Okay, so this is just a different view to the previous slide. So that we were just looking kind of front on. If you were to take a very thin section of the stomach and you kind of look at right at the top, like where are these actual cells placed? This is what it is showing you. And once again, we have the parietal cells, we have the chief cells, which are too important. Now we also have the enterochromaffin cells, right? And also the mucus cells. So later on in the lecture, I will talk about kind of very two broad categories of drugs used to treat these conditions. One which kind of control your acid, and one which control your secretions, right? So that's where the mucus cells will become important. And when we talk about mucus, right, this is the mucus which is covering the entire gastrointestinal tract. And we're talking about kind of like all the way from here, all the way from where your food kind of exits, its last entry, right? Your entire gastrointestinal tract is covered with mucus, right? And if you have some kind of condition which affects mucus production, or basically in the stomach, if you're producing too much acid and this is affecting the mucus, then you will start getting these pathologies which Dr. Marks will talk about, but basically you will get ulcers or you will get dyspepsia as a starter. Okay, on this slide, I do not want to spend too much time. I suppose what I want you to understand from this is that sitting in this lecture room today, we cannot control the amount of gastric acid we secrete into our stomachs, right? Think about blinking your eyes. You can control when you blink, right? It is also autonomic, right? You will blink without being able to control it, whereas gastric acid secretion, you cannot control it. What those various phases are, just for your information, it tells you which phase controls what. If I start talking about lunch, what you had at lunch, or what you're going to have at lunch, that actually might start that process, right? Just that visual or that stimulation in your head that, hey, it's time for food, actually starts the process of that acid secretion in your stomach. Okay, so once again, just for your information. Okay. The top three are something I'd like you to remember. The bottom one, not so much. Okay, so these are the primary neurotransmitters. So we've got acetylcholine, we've got gastrin, and we've got histamine. And we will talk about drugs which modulate each of these receptors, each of these neurotransmitters. Somatostatin, not so much, but I'd like you to, I suppose, think about this in terms of endogenously or in a perfect human or just a normal physiological system. You have to have a system, or you have to have a process, basically your negative feedback. If you're continuously releasing HCl into your stomach, that's not a good thing. You need to have something to stop that mechanism. And somatostatin is exactly what it does. It reduces the amount of, or controls the amount of acid being released into the stomach. Okay. Please stop me at any time if I'm going too fast, or if you have any questions. Or if you want me to kind of expand on this. Okay. On this slide, I want you to remember what is bolded right at the top, right? So we talked about neurotransmitters in the previous slide. In this slide, is where those neurotransmitters act. So right at the bottom, we've got where histamine acts. We've got where acetylcholine acts, so on the muscarinic receptor, and we've got where gastrin acts. On the gastrin receptor, also referred to as the CCKB receptor. All right. Some of you are thinking, do I need to remember GI, GS, GK, the G protein coupled receptors? No, you don't, right? A patient's never going to ask you, hey, which G protein coupled receptor does my H2 antagonist act through? You do not need to know that. If you want to go deeper and understand how your antagonist works, that's how it works, okay, through the G protein coupled receptors. Okay, so something important I wanted to mention in this slide. Let me have a look at my notes. Okay, so you'll see all these your three receptor systems are all kind of pointing to, or all have that effect of what we will talk about is the ATP H and K pump, right? They are all kind of stimulating the insertion of these pumps into your parietal cells. These kind of, I forgot it now. What's the game where the things go around and munch? It's old school game. It's kind of, yeah, Pac-Man. It's completely went mind. I kind of think of these things like Pac-Man, right? They are everywhere in your GI tract, and their not their sole function, but one of their important function is to have these pumps kind of inserted into them. Now, these pumps are not always there, right? When we're talking about those phases of when you think about eating something or it's time to eat food, the stimulation by histamine, by acetylcholine, by gastrin makes these pumps being expressed in your parietal cells, right? So that's also important. Right, what else do I want to say here? That's it. Okay. Ooh, how did that get there? Ooh, I went backwards, sorry. Okay, so the actual kind of pathology. So on the left, so you are one healthy and one gastroesophageal reflux disease stomach over there. Okay, the main or one condition highlighted there is the sphincter. In one case, you have the sphincter working properly. In the other case, you don't. Whereas if you have too much acid in your stomach, or just the reflux, that the acid kind of goes up and into your esophagus, which is something which is not normal, right? You don't want that to be happening, and that can also obviously cause discomfort, right? So if you eat too many loaded fries, right, you can get that reflux happening. And now we will talk about some medication which can, I suppose, help in this. Okay, so I'm not going to cover the disease pathology in detail. So this is the other condition, so peptic ulcers. As you can see, you can get ulcers in your esophagus, in the stomach, and then in the small intestine. And depending on where they are, will depend on what they are called. What they are, I suppose, called or classified or referred to as. In terms of drug treatment, and Dr. Marks will talk to you about this in detail, that certain, so in terms of where the ulcer is, and Dr. Marks will talk to you about this, you can tailor treatment towards that. And also in terms of what the cause of the peptic ulcer is, you can also tailor treatment towards that. But I will not focus on that. I will focus on the drugs and how they work. Okay. So we're getting into the fun stuff. Okay. So what I thought we'd do is we will cover the blue part. So drugs used to reduce intragastric acidity. Then we'll take a 5 to 7 to 10 minute break depending on how much time we have left. And then we'll talk about the drugs which are used in promoting mucosal defense. Okay, so let's start off with the blue. The first group are antacids, right? And most of these are available over the counter, so OTC. I'm sure everyone in the room, including myself, has taken an antacid at some time in their life. As you can see, there are variations of bicarbonates, carbonates, and hydroxides, as well as sodium, calcium, magnesium, and aluminum. One thing I'd like you to take from this slide is what is highlighted over here, is that the magnesium and aluminium hydroxides are often prescribed together. Anyone know why? No? Okay. Think about it. I will tell you when we get to the adverse side effects later on. Okay, so therapeutic uses, so treatment of dyspepsia or intermittent heartburn. This is not something you'd want to be, I suppose, counseling your patient to be taking every single day. Like I said, if you've had a night out on the town, you've had too much to eat, or spicy food or whatever, which has caused dyspepsia, heartburn, you might take an antacid. Okay, everything on this slide you don't need to know. It's just there for your reference. You've got various antacids, both in tablet and liquid form, listed over there. There's this simethicone, which is a surfactant, which is often included in a lot of antacids, and as the slide suggests, it helps in reducing bloating, burping, flatulence. If you've ever taken an antacid, you might think of, or you might remember, kind of 5, 10, 15, up to 30 minutes. It will start helping with your dyspepsia, but it will also make you burp. Some people actually take that because they can't burp. Something else you will also notice is what they refer to as the acid neutralizing capacity, right? Now, I'm sure all of you know pH, right? Lower means more acidic, and higher means less acidic, okay? So all of these compounds have that effect of basically moving the pH closer to 7, right? So neutralizing your acid in your stomach. And based on the dose and what is included, in terms of if it has the magnesium, the calcium, you have different ability to neutralize stomach acid. And this is normally listed at the back of the OTC that you are recommending or counseling. Okay. All right, so how do these antacids work? Well, as the name suggests, these are weak bases, and they work by neutralizing the acid in your stomach, right? So they increase intragastric pH, right? So remember the pH scale, kind of less is more acidic, so we're increasing intragastric pH. How do they specifically work? They react with the hydrochloric acid in your stomach to form salt and water. Now, I don't expect, and you won't be expected to remember those reactions, but it's just there for you to see what happens and which different compounds are formed. Most of the time you will always get a salt, you always get water, and in some cases you will get carbon dioxide. In cases you get carbon dioxide, that is the reason you might get either burping, belching, or flatulence, right? Okay. Adverse effects. All right, so these drugs are pretty good in terms of they are not, they don't have narrow therapeutic index or anything like that, right? So they're pretty well tolerated. So like I keep saying, you eat too much loaded fries, you have too much beer, you feel a bit of heartburn, you take a Tums or whatever other antacid, the issue goes away, right? And that's it. However, regular use of either the bicarbonate or the carbonate compounds which produce CO2 can cause what is called gastric distension, right? And this is where that belching comes from. So if you take these regularly, you'll be walking around like kind of a burping machine, which is obviously not pleasant. All right. That, what I've highlighted, as well as what is something called metabolic alkalosis, right? Now, these antacids can get into your bloodstream, and when they do, they can have the same effect that they're having in your stomach, right? When we talk about alkalosis, it's a short form of alkaline, which is more basic, right? So what it is doing is basically what the drug is doing in your stomach, now it is doing it in the blood, right? It is causing your blood pH to change, to increase, and that is not a good thing. Also, if you think about patients with poor renal function, right? Most of our drugs are renally excreted. So if the blood full of this drug is not being filtered properly, is not being excreted properly, you can have that increase in pH in your what? What does our kidney make? Exactly. So think about drugs which are prescribed specifically to target the urinary system, right? I think I gave away my next. Kind of, almost. Okay, adverse effects. So specifically with aluminium-containing antacids, because of what the salts are formed, some of these compounds are not very well absorbed, and anything which is not very well absorbed, if you remember from the online lecture, can cause constipation. Okay, and there's also too much or too less, so we've got hypophosphatemia, like it says, is relatively rare. Something I'd like you to remember about all these adverse effects and side effects, which I'm kind of mentioning and which are on the slides, is if you're going to take this once a week or whenever you have dyspepsia, it's not going to really result in these adverse effects. If you take them every single day or multiple times a day for a long period of time, that's when you're likely to come across these adverse effects. Okay, so earlier on I asked about why do you think magnesium and aluminium are prescribed or are formulated together? And hopefully the slide gives it away now. The magnesium compounds are associated with diarrhea. The aluminium compounds are associated with constipation. Did I get the right way around? Right, I think so. So prescribing them or formulating these drugs together, you kind of balance the constipation and diarrhea, right? So that's why these compounds are co-formulated. Okay, there's various other rare adverse effects listed there, but like I said, most of the time these are very well tolerated, and because they are short-term medication, it's something which is often not noted. Okay, so I kind of gave this away a couple of slides ago when I talked about the pH of the urine, right? Antacids, they are increasing or changing or modulating the pH of your stomach, right? A lot of other drugs that people take rely on the pH of the stomach to either be broken down, be absorbed, right? Or not, I suppose, intercalate with something else, So it is very important. The very last point is, like it says, most interactions, so most drugs which require specific pH, right, you can make sure or avoid that by taking antacids 2 hours. Now it states 2 hours, but always look at the back of the OTC or the antacid that you are suggesting or counseling, because sometimes it can be up to 6 or even 8 hours. So always have a look at the back of the bottle. All right. Okay, so there's some specific examples there. So the absorption of allopurinol and some antifungals, and then the absorption of pseudoephedrine and levodopa. So these are relatively, I suppose, not drugs which are regularly prescribed, but you have to make sure that any drug which relies on a specific intragastric pH, if your patient is on an antacid, just to make sure you think about that. Okay. And of course, I said about the intercalating. So the aluminium and the magnesium containing antacids, what they do is they will bind to some drugs, right, and not make them easily absorbable. And basically they don't get absorbed, so they don't have their efficacy. So you have to be careful about some of those. And there's some examples. So specifically some of your antibiotics. All right. Is that active? See if you can do that. So I will give you a hint. These questions will be similar to the questions one. I don't know if they're going to ask me to give you exam questions, but these will be, if they ask me to give you exam questions, I'd be doing exam questions similar to this. But these will be exactly, or I won't say exactly the same, but they will be similar to what you do in your post-class quiz. Can you access that? There, and it's supposed to be all anonymous, so I don't know who answered what. All right, so what is the primary mechanism of action of antacids? I'll give you a clue. The answer is not E. Excellent. So we'll get to the HK-ATBAs soon. But antacids, the primary way is they will directly neutralize your gastric acid. All right. Let's do the next one. Excellent. All right. So if you ever come across a patient or you're counseling a patient who has problems with constipation and diarrhea, you want to make sure that I suppose a balance, so something which contains aluminium as well as magnesium will kind of help avoid any other side effects. Okay. I think there's one more. One more? Yes, one more. Let's do one more. Awesome. Don't know how we got 125% for more, but all right. So these are kind of questions you kind of would expect to see in the quiz, or if they ask me to make an exam question, these are kind of exam questions in terms of how do these drugs work, what is the mechanism of action, what are their side effects or common side effects. All right. Anyone have any questions about antacids before I move on? Okay, let's talk about our next kind of group. So H2 receptor antagonists, right? So when I showed you that picture of that, oh sorry.
Are you gonna do the attendance quiz now or like after class?
After class, is that what, or do you normally do it during?
We do it during the break usually.
Okay.
Or at the beginning.
I think it's probably at the end is better because then it would cover what I've covered in the entirety of the lecture.
It should
Oh,
just be,
you're talking
are
about
you
the
here or
host.
not? No, it's like. an
Oh shit!
attendance.
Oh, that one. Sorry. Excuse me. I apologize. Reflux. That was the password.
Capital R.
Yes, capital R. I apologize. Dr. Marks did send me an email and I forgot. My apologies.
That's okay. It doesn't really matter.
I will tell her you were all here.
She doesn't
So is it capital R?
Yeah.
Yes.
All right. Thank you for reminding me. Okay, everyone done that? Cool. All right, let's talk about H2 receptor antagonists. So these are your cimetidines, famotidines, nizatidines, anything as you will see with a tidine. Okay. Make sure you don't get it confused with drugs which just end with an INE, because there are some. These ones end specifically with a TI, DINE, right? So if you're looking for ways to kind of remember, this is one way you can think about these drugs. Okay, so the way I do it, I list like I said in the recorded lecture, you've got your generic name, and then you've got your brand names. Dr. Joyner has told me that it is important for you to know some brand names. So please, when you are trying to remember some of these medications, please think about brand names as well. Rightio, so what do I want to tell you? Ranitidine. Anyone know the story about ranitidine? The story is already written there, so
It got taken off the market because of carcinogens.
Yes. Carcinogens are bad. We do not want cancer.
Because the new one they have is Zantac. It's not the same. It's like Famotidine, right?
Yes.
360.
Yeah, so if you look, so just before class or when I was preparing this, if you go onto, say, Amazon and you look up Zantac, which was the brand name, it now contains famotidine. So Zantac, because it was so popular, you know, your patients would always come to you and say, hey, I want Zantac. Instead of just completely removing it from the market, the company, what they did is they took off ranitidine, which had this risk of NDMA, which is a carcinogen. And the way it happens, it's not only for this drug. They found that a lot of drugs, if you keep them on the shelf for over a period of time, they develop this compound. So it was not just the H2 receptor antagonist, this actually affected several drugs. So ranitidine, specifically that generic, is no longer available, but if Zantac is still available, and that contains famotidine. Okay. So some of the other drugs which I noted in my notes to tell you about was other drugs such as valsartan, losartan, metformin. Some of these drugs also had similar recalls because of this carcinogen issue. Okay, so the therapeutics, like I said, Dr. Marks will talk to you about this. But similar to antacids, they're also used in the treatment of intermittent. So once again, short-term treatment. You can use them for, I would say probably not the primary, and I don't want to say too much because I'll leave it to Dr. Marks, not for the primary treatment of GERD, but probably as an add-on or a supplement treatment of GERD. Okay, so I won't say too much there. I'll let Dr. Marks cover the therapeutics. Okay, let's talk about kind of the structures. All right, so like I said, this is all kind of background information. It's not something I expect you to know. It's not something you'll be examined on in terms of, here's a chemical structure, tell me which drug it is. No, that is not what you are here for. Okay, what I'd like you to appreciate or get from this slide is a similarity in structures between the endogenous compound, which is histamine. So that's what all these drugs are blocking, right? We're all blocking histamine. And I want you to know that during the development of these drugs, scientists discovered that depending on how they change the chemistry of specific chemicals, it changed the strength of the antagonism of these agents. And I'm sure you've heard about SAR. Have you heard about structure-activity relationship? Yeah. So you read about how you can, put a methyl group or extend the amount of ethylene compounds. You can change the way these drugs interact with their receptor. So that's something I'd like you to take from this slide. Okay, back to our wonderful parietal cell. All right. So H2 agonists, they work by blocking histamine from binding to that H2 receptor, right? There's your H2 receptor, right? So what is happening here? We've got the three neurotransmitters. We've got histamine, we've got acetylcholine, we've got gastrin. All of these three receptors have their common focus or their common goal of making sure or inducing the insertion of these ATP H plus K plus channels, which in turn produce that hydrochloric acid in the stomach, right? So by blocking one of them, you reduce slightly the number of these pumps being inserted, all right? So they, like it says, it competes with histamine. And what else do I want to say? Oh, yes. Okay. So the reason why I was kind of saying you still have that histamine, you have that acetylcholine, you have that gastrin, right? You're just blocking one of these mechanisms, right? So you're not going to get like a complete shutdown or a complete reduction of acid in your stomach. What you will get is about a 60%. Like it says, what's the maximum? For cimetidine, you get a 60%. So depending on which drug you kind of use, and also depending on when you take it, right? If you are taking this medication at mealtime, that is the height of when all these receptors are active, because they know, hey, I'm about to get some food. All these receptors are being stimulated. You're getting a lot of the pumps being put into your parietal cells because they're ready for the food to come, right? So they're not as effective, I suppose, during mealtime. But once things have kind of died down, that's when they start to work. I suppose that's when their efficacy is better. Okay, anything else? All right, so like your antacids, relatively well-tolerated group of drugs, very mild adverse effects. And I say that with the kind of, what's the word I'm looking for? With the asterisk of that you're not going to take these long-term, right? These are relatively short-term drugs. Okay, so you got your relatively common diarrhea, headache, drowsiness, muscular pain, constipation. Relatively common, just the way that these drugs work. Less common, like it says, it's in some cases of when this drug is administered through IV, so straight into your bloodstream, you can get some hallucinations and agitation, particularly in elderly patients. Gentlemen, gynecomastia and impotence. Don't worry, if you take this today, you will not have any problems. If you take it long term, you may have some issues. All right. And this is a result of the drug directly working through androgen receptors or interacting with androgen receptors. So that's the why. For women, if it is used long term, you can get what's called galactorrhea. And once again, it is through the activation of androgen receptors. And once again, remember, this is very rare, and it is if you are taking the drug long term and regular. Okay, drug interactions. So similar to your antacids, we are modifying the pH, or we are changing the amount of gastric acid, right? So due to the decreased gastric acid production and any other drugs which require an acidic environment to be absorbed or to dissociate will be impacted. All right, dissimilar. Right? So not similar. So dissimilar to antacids, these drugs do not cause any changes in urinary pH. So that's one thing to kind of remember, where you might want to choose a H2 antagonist versus an antacid if you were giving something over the counter. Okay, cimetidine, CYP450 enzymes. Everyone loves CYP450 enzymes, but we all love to hate them. So CYP, specifically cimetidine, is it goes through the CYP450 pathway, and some enzymes. So if you take other drugs which are either increasing or decreasing the amount of induction or inhibition of certain CYP450 enzyme, you can get an increase or decrease in cimetidine in your blood. So that will increase the risk of some of those side effects. So ranitidine is no longer available, so we don't need to worry about that. And as the slide said, it's mostly cimetidine and not so much the others, because the affinity for this drug to those CYP450 enzymes is higher. One very rare side effect, or one other rare kind of drug interaction, is that these antagonists can decrease the amount of first-pass metabolism of alcohol or ethanol. So very rarely, there have been studies showing that if someone is taking an H2 antagonist and they have some alcohol, the alcohol is staying in their body for longer. So if you're driving, you've been taking these drugs, you've just had one drink, cop pulls you over, you're like, hey, you've got your blood alcohol levels too high. Very rare, and like it says, it varies depending on the individual, but it's always good for you to know in case of counseling your patients. All right, I am motoring through this. Please stop me and tell me to go slower. All right, let's do these questions. All right, where are we up to? H2. All right, what is the primary mechanism? So how do these H2 antagonists work? Excellent. So H2 antagonists, so your cimetidines, famotidines, work by blocking the H2 receptors, and therefore you have less of that signaling to get those pumps into the parietal cells. All right. Let's do this one. How do H2 receptor antagonists differ from antacids? Excellent. So they all have something to do with the acid. It's just the way they are kind of the different ways of modulating the amount of acid or the pH in your stomach. Excuse me. Excellent. All right, any questions before I move on to PPIs? No questions. Awesome. All right, proton pump inhibitors. This is what everyone has been waiting for, because we all love proton pump inhibitors. So we've got the various ones listed there, from the most common omeprazole to kind of getting more common now, esomeprazole, pantoprazole is pretty common, and the other ones, I suppose, not so common but still used. Once again, if you're looking for a way to remember these, look at the prazole. Please don't assume the azole, because we have azole drugs, antifungal drugs. Don't mistake them for that. But most proton pump inhibitors, or all proton pump inhibitors that I know of anyway, will end with prazole. Okay, so if you look at the slide, you will immediately see one thing, right? You will not see that these are used for dyspepsia. You will not see that they're used for heartburn, right? And Dr. Marks will cover this with you a lot more. Anyone know why? Why can't we suggest someone take a PPI if they're having heartburn or intermittent heartburn, or if you just had a big meal and you have a bit of indigestion? Anyone guess? I will tell you why, but anyone know why? It's to do with how the receptors work. Okay, I'll cover that in the slides, and hopefully it will make sense to you. Okay, so this once again is background information, not something which you need to know what the structure of PPIs look like. So the history is the first PPI kind of developed in the lab, or it wasn't marketed, but what they found is that in animal models it caused severe thyroid issues. So the scientists went back to the drawing board, so to speak, and did more of those structure-activity relationship studies, and they eventually came up with omeprazole, which I think for many, 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 many years has been one of the most common drugs prescribed. Or if you look at any country's highest, like which drug is prescribed most or which drug do we fund the most, it is normally a PPI. Okay, so something to think about when it comes to, I suppose, structure. I suppose this is part of structure-activity relationship, is I suppose the strength or the efficacies. So one example I have over there is omeprazole, and then we have esomeprazole, depending on how you want to prescribe it. And as the slide suggests, the S or ES omeprazole is only the S isomer, right? So we have the R and S, but in omeprazole, in esomeprazole, we only have the S. Anyone know why? Why would the drug company go to such efforts to produce a drug with just one of the isomers?
Has like toxic effects, so it doesn't.
Not in this case. And sometimes yes, but not in this case. So omeprazole, remember, has both R and S. Esomeprazole only has the S. Anyone know why? So it has to do with the metabolism. Anyone? So those CYPs, CYP2C19, preferentially likes to metabolize R, omeprazole, right? So they said, okay, we will optimize our drug by not having any R, right? We will just put esomeprazole in our drug, and that will make it, I suppose, more efficacious. So for a lower dose, you can get the same kind of activity. And all of the other drugs you see over there, and I think it's on the next slide, yeah. What I want to mention is all of these PPIs are prodrugs. Someone please give me a definition of a prodrug. Yell it out.
It needs to be converted from something else within the system.
Excellent, right? It needs to be activated. It needs to be broken down to something which will cause an effect. Someone give me an example other than PPIs. Codeine, excellent. Anyone else?
Vyvanse.
Sorry, I can't.
Vyvanse.
5 ands? I'm sorry, my ears are, yell at me.
I said Vyvanse,
Vyvanse.
which is like an ADHD medication.
Oh, okay. I think I know. So like your Ritalin and stuff like that? Yes, okay. Right, okay. So yeah, I'm a different country, new to the US. Some of these brand names are like completely different to me, so apologies. What about clopidogrel? You guys come across clopidogrel yet? Yeah, some people love to call it clopidogrel. Don't call it clopidogrel. When it first came out, people used to call it clopidogrel. Anyway, what I want to say is most or all PPIs are prodrugs. Okay, so I want to spend a bit of time on this slide. Now, once again, I don't expect you to remember the structures, but let's talk about how this drug does what it does. Okay, so I've already said they're all prodrugs. We've discussed that. So once you take the drug, it gets absorbed into your systemic circulation, right, and goes wherever the blood takes the drug. Once it reaches the parietal cells in your stomach, what happens is they diffuse across. Okay? I haven't got something, let me just use this. So the parietal cells, if you think back to some of those diagrams from before, think of where those HK ATPase pumps were placed, right? They were over here. So when you have your omeprazole kind of going across, what happens is it reaches the parietal cells, they diffuse across the cell, which what happens is it results in a protonation. So it positively charges the omeprazole. And this is, if in terms of you want to geek out on this, protonation, what it does is, because it's positively charged, it actually makes the drug hang around near the receptor. Right? That is the effect of protonation. And it basically increases its efficacy, or it gives it a better chance of interacting with the receptor. All right. So why do PPIs work so well? It's because other than that protonation, the active form of the drug, what it does is it forms an irreversible covalent bond. And this inactivates that proton pump, right? We are causing a complete inactivation. And I'm hoping, or I'm sure some of you are thinking then, but why do people have to take this daily, right? Why is it a daily medication or even a twice daily medication? Well, because we want to keep those drug levels up. The amount of inactivation, and when I was asking you why can't you use this for things like dyspepsia and heartburn, it's because that maximal activation takes about 2 to 3 days to happen, right? To inhibit or block enough HK plus ATPase receptors or pumps, you need to be taking this medication for about 1 to 2 days. What else do I want to tell you? Okay, so the pumps, these are regenerated about 20% a day, right? So in about 3 to 4 days, so if you stop taking your omeprazole today, in about 3 to 4 days, you will be back to your normal parietal ATPase pump activity. And the same way around, it takes about 3 to 4 days for it to kind of reach that maximal efficacy. So that is the reason they cannot or should not be used for kind of short-term intermittent heartburn. All right. Something else. Anyone still remember or think back to the packaging of PPIs? Most of them have this delayed release, or they have some kind of special coating on them. Anyone think why? So think back to the previous slide when I talked about the protonation, right? You do not want that protonation to happen in your stomach or in your esophagus when it comes into contact with acid for the first time. You want that protonation to happen once it reaches the parietal cells. So by enteric coating or coating the omeprazole or the PPI, what it does, it increases the likelihood that it goes into your systemic circulation, it reaches the parietal cell, and that's when it has the opportunity to be protonated. Because if it gets protonated before, it's now active, right? And we want the activity at the parietal cell, or specifically at the receptors in the parietal cell. Okay. Right. So, what else do I want to tell you? Right. So I've got a point here that while PPIs work great, we also do not want to completely inhibit all acid secretion, right? So as pharmacists or as a pharmacologist, I'm like, yes, let's block that acid secretion because that's the way we're going to treat the patient. But hang on, acid secretion in our bodies has a function, or there is a reason why we have acid in our stomach, right? Antimicrobial effects, just normal digestion, normal peristaltic activity requires on an acidic environment. So while PPIs work great, we're not blocking all acid. We're not suppressing all acid secretion. But remember, PPIs are, I suppose, the best, or they work great because you're kind of blocking that major HK ATPase pump, right? Okay. Adverse effects. So once again, for most of the drugs that we're going to talk about today, especially in the first half, is most of these drugs, their adverse effects are normally if you take them for an extended or a long period of time. If you're taking them for a few, in the case of PPIs, if it's just you've been prescribed NSAIDs for a period of 3 to 4 months, a PPI is normally prescribed to avoid you getting some of these side effects of ulcers. That is not really going to lead into some of these serious side effects. Serious side effects or long term, we're talking kind of 5+ years of use. What I'd like to also point out is the FDA warnings listed on the slide are not boxed warnings, right? They are just warnings. So that's important for you to know. And it's not just limited to what is listed over there. There are other warnings, but these are the most common which occur. Common, but are rare. All right. One thing to know is decreased absorption of vitamin B12. So when you reduce the amount of acid, it reduces the amount of vitamin B12 which can be absorbed. So if someone already has this kind of anemia, then you really need to watch out. But long-term use of PPIs can result in B12 associated anemia or pernicious anemia stated there. Okay. Talk about that. Okay, drug interactions. So as we have discussed with for other drugs which modulate or increase pH, right? PPIs can also have that effect where the absorption and therefore the bioavailability of certain drugs which require a specific pH, right? It will affect those. And we talked about CYP2C19 a little bit. I mentioned clopidogrel as a prodrug. So if you've got two drugs competing for the same enzyme, and because clopidogrel is a prodrug, you can have a reduction in the amount of clopidogrel being converted to its active component, right? And then that can obviously increase the risk of secondary thrombotic events, right? But once again, this is, like it says at the bottom, different studies have reported different kind of effects or findings. So it's once again, while it's listed, it is not like it's not like a black box or a boxed warning. Okay, any questions about PPIs? I will go and activate this. Right. So really think about, we talked about antacids, we've talked about H2 receptor antagonists, right? Now we're talking about PPIs, and these go right to that central pump and they block that pump and they block it irreversibly, right? And that will stay there as long as you keep taking the medication, right? So you've got these, once again, going back, you've got your histamine, you've got acetylcholine, your gastrin. All these neurotransmitters are saying, hey, put those pumps into the parietal cell so we can get some gastric acid in the stomach. PPIs are blocking that final step, right? That's why they work so well. They take a little while to work, but that's why they work so well. Okay. I've got one more for you. Okay, so compared to H2 antagonists, PPIs are generally considered superior for acid suppression. Why? suppose I spoke too much and told you the answer, but yeah, they block all pathways, or they block that final. All right. I think that is all I have for. Oh, there's this slide. Okay, so reviewing how each of these drugs work. So you got your antacids, so we spoke about. Neutralizes stomach acid. H2 blocks the histamine, and then we've got stops the production of stomach acid completely. In terms of time, right? Antacids, kind of short term. H2 blockers, slightly longer term, and proton pump inhibitors is something which is not recommended or not advised to be used for things like dyspepsia. All right. Up to you. Do you guys need like a 5-minute break? Yeah? All right. Go for a 5-minute break. And it is 12:30. We will come back at 12:35.
Oh, I forgot about that.
All right, let's get back to it. I will make sure that is recording. Awesome. All right. Before I go and talk about the drugs used to kind of help with mucus secretion and things like that, I just wanted to go back to the parietal cell. And just, I suppose this is, once again, this is background information, but I just wanted to, excuse me, go and, I suppose, explain how, oops, my bad. Interruptions, pen. All right, I just wanted to explain how that pump actually gets there, okay? So we talked about that these parietal cells, this Pac-Man kind of looking cell, it expresses a wide array of receptors, which are there, H2, muscarinic, and the gastrin. Those are the ones we've talked about, those neurotransmitters, all right? Endogenously, so normally, so the endogenous ligands, so we're talking about histamine to H2, acetylcholine to that muscarinic receptor type 3, and gastrin to that CCKB. All right. So once either or all of these receptors are kind of activated, you get these downstream or G protein coupled receptor systems, which what they do is they cause this hydrolyzation of that ATP, which you notice there, to ADP, right? Once this happens, you get this H plus ion, right, released into or transported into that gut, into the gut. That's where your H plus is coming from, right? We're talking about how the acid is being formed. So once you get the ATP converted to ADP, you get that H plus inserted into the stomach. Well, how do we get HCl? Because there's another pump which will secrete chloride. And to keep everything in balance, why is it called an H and K plus? You have a potassium ion which is brought back into the parietal cell. Why am I going back to this? I just thought it would be important for you to kind of get a brief idea or a basic idea of how you get hydrochloric acid being formed in the stomach. Okay. Let's go. All right. Okay, drugs that promote mucosal defense. So whenever we talk about protecting the GI tract from things like pepsin and acid, we need to think about and remember three main mechanisms listed over here. So you've got your epithelial, bad, let me get that. You got your epithelial tight junctions, you got your mucus, which we'll talk a lot about, and we've got your bicarbonate, which is kind of related to the mucus. Okay, so like it says, the tight junctions form this very small intercellular barrier, which kind of just block that. It actually blocks the acid from reaching your epithelial or your stomach lining. The mucus, like it suggests, is just a pretty thick mucus layer, which just protects your acid from hitting your epithelial or your gastrointestinal lining. Then we have compounds such as bicarbonate ions, and if you're thinking, hang on, antacids, bicarbonate ions, yes, right? So they're bicarbonate ions secreted by these epithelial cells into the mucus, and if you have acid actually getting into the mucus, it will neutralize that, right? So there's another mechanism by which you are reducing or preventing gastric acid from kind of impacting your epithelial lining. Okay, so in terms of drugs which help, we have sucralfate. So I have issues with pronouncing drug names. This is one of them. Like the slide suggests, the mechanism is unclear. So you will not get a question with saying, how does this work, right? How does it work in terms of how it's thought it works is, where is it? So it binds the positively charged damaged proteins to form a protective layer. So what is hypothesized or what is thought is when you have, a peptic ulcer, right? If this is a peptic ulcer, normally what happens is they are positive. Oh, my positives are very bad. Right? If this is your ulcer in your gastrointestinal lining, right, normally it has positive ions on top of it. What this compound does is it is negatively charged. It will come and it will bind on top of where your ulcer is, and it will help or protect from further damage. Once again, like I said, Dr. Marks will probably talk about this in greater detail. Excuse me. But its clinical use is relatively limited. Prophylactically, if you have a patient who is, I suppose, bedridden or for some reason, this drug may be prescribed to them just to make sure that their stomach acid does not create what is called stress ulcers. So it is used quite a lot for that. Adverse effects, once again, relatively well tolerated. These drugs are not used that long term. Once again, because of the aluminium salt in it. Sorry, I say aluminium. I know you say aluminum. Because of that, it can cause that constipation like we talked about before. Like it says, for a lot of these drugs we've discussed today, I've mentioned renal insufficiency. So prolonged use is avoided or should be avoided in patients who have some kind of renal failure, be it acute or chronic. Okay, and just because of the nature of the way the drug works, right, we are collating. So if you are, these drugs can bind with other co-administered drugs and make them not be absorbed into the systemic circulation. So be wary of that. So like it says, they can cause insoluble complexes. And this is the same reason why they can cause constipation as well. Okay, so this drug I spoke about when we talked about in the constipation diarrhea lecture. So this is a salt of bismuth and salicylic acid, right? And I'm hoping that is already ringing bells in terms of, hey, is that aspirin? Yes, it is. And you will talk about NSAIDs, I think, next week or in a few weeks' time, where you'll learn more about this. Okay, once again, this is one of those drugs where the precise mechanism of action is unclear, but here is how they think it works. One thing I'd like you to know is when you take this drug or when you take this compound, when it comes into contact with the acidic environment in your stomach, you get it being dissociated or broken down into its salt, bismuth salt, and the salicylic acid. And that's one of its ways how they think it works. It can stimulate prostaglandins, which in turn can stimulate bicarbonate and mucus secretion, which is a good thing, right? That's how they think it's working. All right. So I talked about that dissociation. So you take the medication, it comes into contact with the acid in your stomach. You get it broken down into the salicylic acid and the bismuth oxychloride, which is your salt. So the bismuth is extracted in the stool, whereas the salicylic acid mostly through the urine. Some adverse effects to think about, and I mentioned this in the other lecture. So the bismuth compounds, it can react with sulfur and it can create these dark or purple-brown pigments, right? Both in the intestine as well as some people might actually notice it in the lining of your mouth. So if someone is taking these relatively long term, you can get that pigmentation in your mouth. What else did I want to tell you? Okay, Ray's syndrome or Reye's syndrome is a result from that salicylic acid component of this drug. This, once again, is very rare, and the way it works is the salicylic acid can react with mitochondria in the liver, which leads to impaired fatty acid metabolism, which can then result in a buildup of ammonia and central nervous system or CNS toxicity. Once again, very, very rare, just for you to be aware that this can happen in children and teenagers who are recovering specifically from a viral illness. And the reason is because this drug is kind of targeting that mitochondria. All right, so the last drug, I think. So misoprostol, specifically this brand name. So speaking with some of the pharmacists, they said that this is one of those drugs where you should really remember this specific brand name, the Cytotec. Okay. All right, so like the slide suggests, it's an analog of prostaglandin E1. Now you will learn a lot about prostaglandins. I think it's Dr. Hengen who will come and speak to you about NSAIDs, and you will learn about these prostaglandins. In terms of the mechanism of action, it's a bit tricky when it comes to all of the naming specifically and what it interacts with pharmacologically. Now, while on the slide it indicates that it binds to the E2, type 2, 3, and 4, the main one you want to remember is the type 3, specifically for this drug. All right. So binding these receptors, or binding that prostaglandin receptors, helps with mucosal defense by promoting the defense layer. So more mucus, more bicarbonate, and also it has the effect of decreasing or inhibiting acid secretion. The therapeutic uses, as listed there, excuse me. This drug was originally thought or developed for preventing NSAID-induced mucosal injury. But it has other off-label uses, and you may have actually studied or come across it, that this is actually used a lot in things like pregnancy as well. So non-GERD uses. All right. Wonderful diagram. I always find diagrams useful when I am studying. Just so if you're looking for a way of how do I remember these drugs, I would draw a big parietal cell. I would draw those receptors. I would remember the neurotransmitters, and I would basically put all the information there. This is an overload of information. I want you to focus down here where it says NSAIDs. Now, like I said, Dr. Hengen will come and talk to you about this. And you will learn, or you will either refresh your memory on things like COX-1 and COX-2, prostaglandins, and how NSAIDs work. So I'm not going to go into that. What you need to know for misoprostol is that by agonizing, right, these are analogs. So by agonizing the EP3 receptor, so this receptor, you reverse the effects of the NSAIDs, right? So what you see on the slide is what NSAIDs are doing. But by reducing the amount of acid being released, right? So you're using this, and as well as increasing mucus production. Right. So NSAIDs have that bad effect of causing ulcers and things like that, and Dr. Hingen will tell you why. It is through this EP3 receptor as well. That's why when these drugs were developed, it's like, hey, we can actually just block the effect of the NSAIDs at that specific receptor. So that's how they work. So if you're thinking, if you're looking at a question, specifically a pharmacological question, how do they work? Think about prostaglandin analog, think specifically the EP3 receptor. All right. Now, as wonderful as this drug might sound with its kind of dual action of reducing acid and increasing secretion or increasing that mucus layer, it is associated with some relatively severe adverse effects. As you can see, you can get cramping in up to 30% of patients. And due to its mechanism of action, prostaglandin receptor activation, it is not recommended in patients with inflammatory bowel disease because in cases of inflammation, that is actually through the prostaglandins. So you don't want to be prescribing an analog which can make things worse. Okay, and then lastly, you'll note on the slide that this drug, specifically the brand, that's why I've mentioned this is one of those drugs where you want to remember the cytotec, can cause birth defects, right? So things like premature birth, and in terms of in pregnant women, it can cause uterine rupture, and due to prostaglandins increasing the force of contractions. That's what they can do in the uterus. All right. And like I said, I'm not sure if you have come across it, but misoprostol is used quite a lot also in women during pregnancy. So in terms of if you want to induce labor, it's also used in cases of abortion. It's used to manage excessive bleeding after childbirth. Right? So it has various non-GERD or PUD uses, which you might come across. But it's not one of those cases which, someone comes to you and says, hey, I've got dyspepsia, or I've got heartburn, or I think I've got an ulcer. The first thing you're not going to counsel them is to take this drug. It's relatively rarely prescribed. Okay, so I don't have any questions for the last 3 drugs we discussed. You will have questions in the end of class quiz. If you have any questions about this or the PPIs or antacids, I am going to hang around for a while. Otherwise, if you don't, happy Halloween. And please feel free to come find me or email me questions. Thank you.
What time